true pleasure for me to be part of this exciting meeting. I was looking through the program, and it's a very, very interesting meeting. We don't have something like that in Germany, so I can only congratulate you. Here are my disclosures. And I was asked to give an overview over HER2-positive breast cancer, about early breast cancer, metastatic breast cancer. So I will talk a little bit about the standards of care, about new developments in 2021, because you're reviewing the last year in your conference. So I try to focus on recent data, show you the guideline recommendations, and also where the research is going. And I don't know whether we have time for questions, but I'm certainly be happy to answer any at the end of the talk. Could you shut down all the microphones, because I have an echo. It's difficult to concentrate that way. Thank you. So you've probably seen this graph before. This is a paper published by myself and other distinguished colleagues around the world on the therapy standards in early breast cancer in Nature Reviews 2 years ago. And for the HER2-positive setting, actually, in the early breast cancer setting, we didn't need to make so many amends in the last 2 years. But for the metastatic setting, obviously, there's lots of new drugs approved. So the picture now looks like a little carpet with patches here and there. So HER2-positive early breast cancer, about 15% of the cases, and actually the main standard of care is neoadjuvant therapy, and then escalation or de-escalation based on the PCR status. And only in the small node-negative tumors, we would recommend primary surgery followed by chemo based on the APT study. So this last year, we had this wonderful overview of Trastuzumab in early breast cancer, whereas it's not the standard of care anymore to do this in an adjuvant fashion. I think it's still important to see these long-term data and see what we have achieved. So basically, we can reduce recurrence and mortality by a third. And I think that is a very, very important message. The meta-analysis is very strong with regard to the studies that looked at 1 year of Trastuzumab. I will come later to the shorter versus longer duration. There, unfortunately, only one trial delivered its data, but there was this meta-analysis at ESMO, which we saw earlier last year. So very good publication also to talk to patients about. And I think it's also important to state that whatever we've made with regard to progress in this setting, if there isn't availability or the patient cannot afford these new drugs, Trastuzumab by itself is actually a milestone forward, and everything else comes on top of that. But if the standard therapy, the old standard therapy, is still much better than no anti-HER2 therapy. And here what you see is the recurrence and breast cancer mortality, but there's also interesting data on the hormone receptor positive, hormone receptor negative cohort. And what we see there is that basically outcome is quite similar, but the dynamics of the relapses are different. In the ER negative setting, it's much earlier, and in the ER positive setting, relapses come in the second 5 years. So the only indication where we still do primary surgery, unless the patient obviously wants it otherwise, is this small node-negative tumors with a distant recurrence rate of 1% after 7 years, as nicely published by Sarah Tolani 2 years ago in JCO. And you can also extend the small node-negative tumors up to 3 centimeters based on this trial, but there was only 10% of these large tumors in there. So we in our country have decided to sort of recommend it for tumors up to 2 centimeters. And the reason we've changed our treatment and went to neoadjuvant therapy is because neoadjuvant therapy, first of all, gives us a lot of patients with PCR, as you can see in the lower right-hand graph, more in the ER negative than the ER positive, HER2 positive setting. But the PCR is also correlated with outcome, and more so in the ER negative than in the ER positive setting. Here we see the more modern chemotherapies in the Trifina trial, a small trial that was actually looking more at cardiac safety. But we can see here that we can achieve this is in breast PCR rates around 70 to 80% the ER negative population and about 50% in the ER positive population. The other thing you see on this slide is that it really doesn't seem to matter so much what chemotherapy backbone we have, provided that we have optimal anti-HER2 therapy, whether it's anthracycline taxane sequence, like in the left two bar graphs, or in the anthracycline free component. The PCR rates look rather similar. And this was also shown some time ago already by the TRAIN-2 study, our Dutch colleagues that investigated a somewhat unusual regimen of paclitaxel plus carboplatin plus dual HER2 blockade, followed by FEC, and FEC also given with the antibodies together, and in an anthracycline containing arm, and the anthracycline free arm just had the platinum and the paclitaxel 18 cycles. It's not something that we usually do in this setting. And you can see here that the efficacy PCR and EFS are quite similar between these two study arms. And we've changed in 2020 our use of anthracyclines in HER2 positive disease. In Germany, we have access to the optimal anti-HER2 drugs with health insurance coverage. So we changed to an anthracycline-free chemotherapy based on the TRAIN-2 study, but not just based on the TRAIN-2 study, but also on the overwhelming evidence that actually, I showed you Trifina, there's also BCRG06, that you cannot accomplish much more if you include anthracyclines, but you will have more side effects. This is seen quite differently across the globe, whereas the NCCN readily adapted all these anthracycline-free regimens in their preferred neoadjuvant regimens. You can see on the lower right-hand side that from the St. Gallen meeting, actually the majority of the consensus panel said we still want anthracyclines to be part of the chemotherapy regimen. What was discussed at St. Gallen was that particularly if you don't have access to the optimal anti-HER2 therapy, anthracyclines do give you better efficacy. But once you have optimal anti-HER2 therapy, the use of anthracyclines and the efficacy is more than doubtful. So the other data set looking at escalation and de-escalation was actually this interesting meta-analysis by Dr. Earl shown at ESMO this last year, where she compared all the short Trastuzumab trials with the standard duration of about 5 trials here altogether. And this patient-based meta-analysis was able to show that whereas for the 9-week regimens, you cannot show non-inferiority 1 year of Trastuzumab, you can show non-inferiority for the 6 months regimens. Although we have to keep in mind that this data is largely driven by the Persephone trial, which was the only single trial that showed that 6 months is as good as 12 months. And this is, I took this from the discussion of Dr. Picard at ASCO when the trial was presented. And Martine very rightly pointed out that there is still doubt about several subgroups that are actually clinically quite relevant. The neoadjuvant, the concomitant trastuzumab with chemo, the anthracycline-free regimens, or the ER-negative population, where we cannot say that 6 months was as good as 12 months. So I think the verdict is still out there. We don't know from the meta-analysis the subgroups. We haven't seen them at ESMO, so we still have to wait. But I think for the time being, there is a lot of data that 6 months isn't all that much different from 12 months. So if patients cannot afford 1 year of anti-HER2 therapy, I think we can sort of comfort them and say, well, you've achieved a lot if you can afford a 6 months period. With regard to the optimal adjuvant anti-HER2 therapy, single or dual blockade, we have data from the Affinity trial, which was finally also published last year by Dr. Picard, and I saw it on your agenda as well as one of the highlights of 2021, the full publication. And what we see here is that the benefit is confined to the node positive group. In node negative patients, we do not see a benefit from adding pertuzumab, but in the node positive group, we do see this benefit with about 4.5% at 6 years, which is quite substantial. We do not see a difference with regard to hormone receptors. I have to point this out. So this is independent of the hormone receptor status, but node positive patients would warrant 1 year of pertuzumab as the optimal adjuvant therapy. And for the lack of any randomized data after PCR, we also sort of transfer these data and say in patients with PCR who eventually were at some point node positive, please also add pertuzumab if you have the opportunity to. The Kaiklin study was also finally published last year by Dr. Kropp as the first author in JCO. It was a trial that wasn't given that much attention because it didn't reach its primary endpoint, because it couldn't show that TDM1 plus pertuzumab is as good as paclitaxel plus dual HER2 blockade, or even better than that, which was the primary endpoint. But we can see that it's as good. And the green curve is our standard regimen, adjuvant therapy, AC, paclitaxel plus dual HER2 blockade. And you see how well these patients actually do at 3 years IDFS with 94%. So 1 year of dual HER2 blockade, also in a second study besides Affinity with the node positive situation, shows that this is very effective therapy. And here again, the experts worldwide seem to agree, as shown here by the St. Gallen panel, that in node negative patients, nobody would add pertuzumab in the adjuvant setting. So I think that standard is very clear worldwide. With regard to the non-PCR patients, we know from the Catherine trial that replacing trastuzumab with TDM1 is actually better. You can see this here in the analysis presented at ESMO Breast 2 years ago, where the investigator sort of broke this up by hormone receptor status. It's also last year published in Annals of Oncology, this data. And you can see here that TDM1 is better independent of the ER status, but overall in blue, the TDM1 arms, and in magenta, the trastuzumab arms. Overall, with the straight lines, you can see here that TDM1 is better, but in the receptor negatives, with the dotted lines, it just the prognosis is a little bit worse than in the receptor positives. But this median follow-up, we talked about how the events in the ER negative positive population will come at a later stage, and this is just a 3-year follow-up. So we're expecting probably to see a little bit difference with regard to the hormone receptor status in the next follow-up. After TDM1, for example, or after dual HER2 blockade in patients with high risk, and in Europe confined to the hormone receptor positive population, neratinib has shown an effect with regard to preventing metastasis. As you can see here, about 5% absolute difference at 5 years in the EMA population, which is hormone receptor positive, and within a year of adjuvant trastuzumab-based therapy. We offer this to our patients also after TDM1, but we tell the patients that this study was done after trastuzumab, and we don't have an idea whether the absolute magnitude of benefit is similar or slightly less if you have other HER2 agents already included in the treatment algorithm. But the data on in the small subgroup of patients with non-PCR is even more convincing, with an overall survival advantage of around 7%. So where do we go with regard to research? This is from our own ADAPT experience, the hormone receptor positive, HER2 positive trial, the study with the 4 cycles of TDM1, where we could show that patients with a PCR under just 4 cycles of TDM1, actually they survive much better than patients without a PCR. And that in the patients with the PCR, you can see on the very right-hand side, it really doesn't matter whether they get further standard chemo or not. So basically, the results you see there in the green curve on the very right-hand side is patients with just 4 cycles of TDM1 plus trastuzumab after surgery, no systemic chemotherapy, and they're doing extremely well. So this is sort of the basis of further de-escalation trials. And one could also see when we talk about Tdxt later, what you could achieve with just 4 cycles of Tdxt, probably higher PCR rates than the 40% observed here. We also have data for the hormone receptor negative HER2 positive subtrial, where we gave 12 times paclitaxel plus dual HER2 blockade, as you can see here on the right-hand side, the right-hand side of the left graph, where you can see the PCR rates of over 90% in this group. And these patients do extremely well on the right-hand side. Everybody with a PCR has an excellent outcome. And some of the patients in the PCR group, just by the 2 antibodies alone, didn't get any further chemo, and there was no IDFS event in that group. So patients with a PCR, independent of how they get there, they do extremely well, and they may not even need further standard therapy. At ASCO last year, we presented this, at San Antonio last year, we presented a small trial also from the ADAPT umbrella, sort of at the WSG, the Key-Ridged-1 study, where we took the HER2 positive tumors and did a PAM50 and took the HER2 enriched population and treated them with trastuzumab, pertuzumab, and pembrolizumab. It was only a small study, around 50 patients actually treated. But what we can see here is that with this pre-selection, you achieve PCR rates of around 50%, higher ones in the ER negative than the ER positive population. And we will need to see the outcome. A lot of the patients with a PCR did not want to have further chemotherapy, and we're expecting to see outcome in a year or two. So what is the standard of care with regard to trials for escalation and de-escalation? You can see here that there is a lot of escalation trials on the right-hand side basing on TDM1, be it with immune therapy or tucatinib plus TDM1, or replacing TDM1 with Tdxt. So a lot of trials there, but also on the upper part, the de-escalation, the large international consortia, which are looking the same backbone we did in ADAPT, 12 times pacli plus dual HER2 blockade, and then afterwards de-escalating further or escalating based on PCR status. So a lot of interesting trials ongoing. So what is our standard of care at the year 2022? This is something I presented at St. Gallen last year, which is going to be published very soon. Basically, what we talked about, small node negative tumors, take them to primary surgery. If the patient stays small with a small tumor node negative, then the EPT regimen. If the patient turns out to be node positive, that can happen in about 10 to 20%. You can always use an adjuvant polychemotherapy with dual HER2 blockade, like in the Kaiklin trial, with excellent outcome results. And in all other patients, neoadjuvant therapy, preferably from my point of view, without anthracyclines, and then escalate or de-escalate based on PCR status. And in those hormone receptor negative high-risk situations, I would talk to the patients about neratinib, with the caveat that maybe the absolute benefits are less than expected by the extenet data. And if patients have problems with the tolerability, they should not continue, because only if patients were able to take this for about a year, 11 cycles, they actually had a benefit. So, but we have a trial right now in Germany, the Eleanor trial, which we presented early results at San Antonio, and that actually seems to work pretty well. And there's a lot of interest by patients in protecting themselves even further. So for the last part of my talk, let's look at the metastatic setting. As I said, same paper, different algorithm here for the metastatic breast cancer. And we can see that in the HER2 positive space, there's a lot of new drugs that are coming and moving upwards towards earlier lines of therapy. All of them, the yellow ones, are approved in the US. In Europe, we only have an approval for Tdxt and tucatinib in the metastatic setting so far. So what are our standards? The standards, certainly in the first-line setting, taxane plus dual HER2 blockade based on Cleopatra here with these landmark analyses, 8 years, and now published by Dr. Swain with a 14% difference in 8-year overall survival favoring dual HER2 blockade. In the second line, before September of last year, our standard used to be T-DM1 with very powerful survival data from the Emilia trial with a significant overall survival advantage, even though about a third of the patients crossed over to T-DM1 from the control arm. Still, T-DM1 was better. Clear evidence showing that the earlier use in ADC, the better. But with ESMO last year, this second-line standard has changed. We now have Trastuzumab deruxtecan, which is also an ADC with a different chemotherapy backbone, with a higher drug-to-antibody ratio, and with a cleavable linker, which makes the actual compound being internalized into the cells really small, and that's why we also see a bystander effect with Tdxt. The overall response rate is fantastic with this drug from the DESTINY-Breast03 study, with only 1% of the patients with primary progression compared to 17% in the T-DM1 arm. And then I think this, if I could pick one slide, which would be my slide of last year, I think that would be it. Tdxt outperforming T-DM1 with regard to PFS. The DESTINY-Breast03 study reached its primary endpoint with a hazard ratio of 0.28. We don't see this that often, probably never before in this setting, so in metastatic breast cancer. So I think this is wonderful news for patients, because we shouldn't forget that T-DM1 is a fantastic drug itself, and it's quite effective. We have a patient at our site who's now like 7 years stable with liver mets on T-DM1 in complete clinical remission. And I think this is a fantastic drug. So outperforming this by such a margin, I think, shows us what powerful agent Tdxt actually is. And we saw at San Antonio the confirmed response rates in the different subgroups. And we see here that there is always a difference of around 40 to 50% in each individual subgroup. And particularly on the lower side of the slide, you see the patients with stable bone mets, and you can see that again here, these patients respond much better to T-DM1 than to Tdxt than to T-DM1. And here's the Kaplan-Meier curves for patients with and without brain mets, and you can see there's hardly a difference in efficacy. So showing how good this drug works, at least in patients with stable bone mets. The overall survival data is not significant by study criteria, but still it's going in the right direction. But it also shows us that patients in the second line setting still have quite a good prognosis with these effective therapies and can live for some time with their disease. The tolerability of Tdxt is quite good. We have blood value alterations, we have GI toxicity, and we have a little bit of alopecia. The only thing we were worried about was the ILD or pneumonitis, because in the predecessor phase 1b, phase 2 study, we saw 5 deaths with Tdxt. So there was a lot of proactive management, early detection, proactive management, drug interruption, stopping of the therapy. And we can see that this was really, really effective, because here grade 3 toxicity is 0.8%. So if we only had seen those data, we would say there is nothing there but now we know we have to be really careful. And if we are careful and proactive in our management, patients can be treated quite safely with Tdxt. The other new drug that's available in Europe, at least, and in the US, is tucatinib. It's a small TKI, and in the registration study in patients with prior trastuzumab, pertuzumab, and T-DM1, tucatinib outperformed the control arm with trastuzumab and capecitabine in all regards. It was better for PFS, better for overall survival, and better for PFS in patients with brain mets. So what we saw, San Antonio, was an update of the HER2CLIMB study with additional about 1.25 years of follow-up. And we see here that the survival advantage, progression-free survival here for patients with brain mets is still there. And we also have a confirmed response rate in the brain of about 45% compared to 20% in the placebo arm. So very, very strong data here for brain mets, and also the overall survival still is improved by tucatinib with a median of 9.6 months improvement, and in the stable brain mets it's still 5.2%. So tucatinib is a good drug that preferentially also works well in the brain, and we have incorporated that in the new ESMO metastatic breast cancer guidelines. I'm really proud to say that that was also published last year, and it was quite an effort. We started in spring and had them ready by September. And if you look at all the different authors, you can see that there was a lot of opinions there, a lot of very fruitful discussions, and I'm glad and I'm really grateful to the group to get this done, and particularly to Dr. Gennari, who really pulled the strings together. When here, there's very interesting algorithms in there, so you might find them helpful for your patient management. And here in the HER2 positive setting, we have clearly stated, based on the data I've just shown you, that first line is clear, it's the Cleopatra regimen. Second line, we would prefer tucatinib if there is active brain mets where we cannot do local intervention. But for all the other tumors, trastuzumab deruxtecan would be our preferred agent in the second line setting. So just to summarize, in early HER2 positive breast cancer, neoadjuvant chemo plus dual HER2 blockade is our current standard in tumors larger than 2 centimeters. And non-PCR, we escalate with T-DM1. Primary surgery for the small node negative tumors with the APT regimen. The optimal duration, I would argue, still remains 1 year of anti-HER2 therapy, although the data accumulate that for certain patients, maybe 6 months is also enough. And it would be interesting to have the subgroup analysis of this meta-analysis presented at ESMO last year in order to see for which patients we probably need to have a longer therapy. Extended adjuvant therapy with neratinib is an option for high-risk hormone receptor positive disease. And if at all possible, if you have the access to these trials looking at de-escalation and escalation with the new drugs, I think that is a good way forward. In the metastatic breast cancer setting, Tdxt replaces T-DM1 as the second-line standard, and we're waiting the European approval for this particular also second-line setting in February of this year. Tucatinib is effective in active brain mets and also in patients without brain metastasis, and would rank in third line after Tdxt, except for patients with active brain mets. And obviously, there's also ongoing trials looking at sequencing of the available therapy options and also management of brain mets. We have the Destiny Breast 12 study where all patients get Tdxt, and it's a question whether they have brain mets or not. And then there's other trials with Tdxt trying to place this molecule in the first line setting. And with that, I would just like to conclude with coming back to the original title of my talk. I think the HER2 story will continue. It has continued very substantially last year and the year before. And I would say the future looks really bright. What I assume is it's going to happen. We move all these interesting agents forward, and we will have higher cure rates in the early breast cancer setting, hopefully, and less patients with metastatic HER2 positive disease. And with that, I'm just returning back to my chairs in India. And thank you so much for having me at your conference. Thank you very much.